for today's discussion is ECG diagnosis of chamber enlargement and hypertrophy, causes and limitations. The outline of the talk would be divided into what is a normal way to see whether the patient has a normal ECG, atrial enlargement, ventricular enlargement, low voltage complexes, the limitations and summary. So what is normal ECG in terms of enlargement or hypertrophy? If we see, the axis is very important both for the atrial enlargement or the ventricular enlargement. The atrial as well as ventricular axis should be between 0 to 90 degrees, and any change more than -30 or plus 120 would be regarded as left axis deviation or right axis deviation respectively. The other aspect is the transition of the QRS. The normal transition occurs from V2, V3 or V3, V4. If it occurs late, it is a late transition. If it occurs early, it is an early transition. Also, the voltages are dependent on the P wave as well as the QRS are to be within a normal range, and that will be described as with the enlargement. So, based on the frontal as well as the vertical axis, the enlargement and the axis deviation is decided, and thereafter that is how we will be diagnosing the atrial enlargements. So if you see a normal P wave, we would see in lead 2 and lead V1. A normal P wave doesn't have more than 3/3 squares in lead 2, while in V1 the initial part and the terminal part, there is an initial part and a terminal part. The terminal part doesn't exceed more than 1/1 square in a normal person, and the axis of the P wave is generally within 0 to 90 degrees. In a right atrial enlargement, what happens is the P wave becomes more peaked in lead 2, giving it a pointed appearance, and even in V1 it becomes pointed with the terminal being less very evident. While in left atrial enlargement, the P wave in lead 2 becomes more broad and notched in between, and in V1 the initial part is followed by a prominent negative part which is called P mitral, and that is suggestive of left atrial enlargement. When there is biatrial enlargement, you will have a combination or with an axis which changes. So how does this occur? Understand the mechanics of it. The initial normal P wave is consisting of a RA depolarization followed by an LA depolarization based on the axis, and when they fuse together you get a good rounded P wave in lead 2. While in V1, the initial part, which is the RA part, is positive, while the terminal depolarization is the LA part, which is negative, and that is why you get a positive negative. So if you have what we call as a right atrial enlargement, the atrial A, the RA part will get taller and the terminal part will get lesser, and therefore you get a peaked P wave in lead V1 in right atrial enlargement, while in left atrial enlargement what you get is the LA part which gets more, and therefore the terminal part being more is suggestive of a more wider as well as a deeper terminal negative complex in V1, which suggests left atrial enlargement. In lead 2, because of summation, the right atrium and the left atrium, it becomes peaked, while a terminal left atrial will increase the duration of the P wave as well as cause it to be notched. So a notching and a increased duration suggests left atrial enlargement in lead 2. So again, revising the same, lead 2, increased height more than 2.1 mm, 2.5 mm, and terminal lesser negativity but increase in the initial part of more than 1 is suggestive of a right atrial enlargement, and it may be associated with a right axis deviation of the P wave. While in left atrial enlargement, the P wave duration increases and there is a notch in between, and the terminal negativity is more than 1/1 box with a left atrial axis of depolarization being more than 0 degree. So what are the causes of left atrial enlargement? You will have rheumatic heart disease or valvular heart disease, left ventricular hypertrophy, dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy or congenital heart disease. And left atrial enlargement, which is also called as P mitral, the criteria are different, but what is most important is specificity. So if you have a notched P wave with interpeak duration of more than 40 milliseconds, it is the most specific sign. P wave duration itself only without a notch is less specific but more sensitive, and the P wave duration to the PR segment ratio of more than 1.6 is also sensitive as compared to otherwise. However, the sensitivity doesn't cross more than 50%. So to make it more sensitive, you need to see lead V1. In lead V1, if the negative P wave duration is more than 1 by 1 square, it is actually sensitive as well as specific. So that is a P terminal force of more than 4 milliseconds in V1, that is we call the Morris index. If it is there, it is equally sensitive and specific. So the limitations are basically the sensitivity and specificity. You need to apply various criteria, and the more the specific the criteria, it is less sensitive. So let us see some examples. You see here, this is specially for atrial enlargement. So what we see is for the P wave, and what you see in this P wave morphology, it is a P wave duration is more than 3 squares, that is 120 millisecond. It is notched in between. If you see here, the notch is there, and the P to PR segment ratio is more than 1.6. Also in V1, what you see is a negative P wave which is more than 1 square depth and more than 1 square duration, and the P terminal force is 4 millivolts millisecond. Now coming on to right atrial enlargement, which is also called P pulmonale. The right atrial enlargement mainly is diagnosed by more than 2.5 millimeter in the inferior leads, and in V1 and V2 more than 1 square, exactly being 1.5 millimeters. Now along with that, a QR in V1 in absence of MI is also considered as right atrial enlargement, and the causes of which can be severe PAH, congenital heart disease including severe PAH, STOF, ASD, PAPVC, shunts, Epstein's anomaly, COPD, valvular heart diseases like TS and TR, and cardiomyopathy which includes ARVC, Uhl's anomalies and others. So right atrial enlargement on ECG, if you are seeing that the inferior leads have a tall peaked P wave of more than 2.5 and the initial part in V1 is more than 1.5. Also you may have a QR in V1 and it may be accompanied as a soft indicator by RS ratio in V1 more than 1. Again, the same limitations arise. The sensitivity is less of all the ECG criteria, but if they are present, they are very specific. Biatrial enlargement can be present with cardiomyopathies and valvular heart disease, restrictive cardiomyopathies especially, and congenital heart disease. So if you have a presence of initial component of V1 more than 1.5 and deep negative also more than 1, or if the P wave voltage is more than 2.5 with a duration of more than 3 squares in lead 2, or a combination of two or three more things, it may suggest a biatrial enlargement. It's very important to understand that biatrial enlargement, if it is present, it suggests biventricular disease to a certain extent or a bivalvular disease to a certain extent. So biatrial enlargement, the example in this case, if you see here, there is a peaked P wave in lead 2 which suggests a right atrial enlargement, and a P terminal force which is more than 1 by 1 in V1 of the P wave suggests left atrial enlargement. Going on to ventricular hypertrophy, let us understand hypertrophy. The two major types are concentric, where it occurs because of pressure overload, which is because of hypertension or aortic stenosis. The others being hypertrophic cardiomyopathy or restrictive cardiomyopathy. Now, concentric type of hypertrophy is generally related to pathophysiological conditions, hypertension or relative increase in connective tissue and fibrosis also. Eccentric hypertrophy on the other hand is generally related to volume overload and may be associated with valvular heart disease or dilated cardiomyopathy. It may be related to dynamic exercise and may be physiological adaptation in certain people, related to obesity also, and here the relative increase in myocytes is there. So eccentric enlargement is generally associated with the increased preload, while concentric is generally with an increase in the afterload. Now if you see the types of increase ventricular enlargement or hypertrophy, increased LV mass is generally either concentric in nature, where the mass increases, it becomes thick, but the cavity doesn't increase or actually decreases. Otherwise it can be both thick and dilated, while in an eccentric type it is more of dilatation as compared to the volume. So the muscle myocytes may be lesser and the volume is more, that is eccentric, as compared to concentric, where the muscle mass or the thickness increases as compared to the volume. So let us see about LVH, concentric pressure overload type, and what you need to understand is the basics. Whenever there is LVH, the muscle mass of the septum as well as the LV apical and lateral wall may increase. So whenever it is concentric, more the axis shifts to the left, there is an increased QRS voltage of the left sided lead. So from a normal voltage, the voltage would increase. Because of an increase in the LV mass, the increased duration of depolarization will cause an increase in the QRS duration. There may be STT changes because the repolarization then becomes abnormal and it may give a strain pattern. Because of an increased LV mass, the left atrial can become enlarged and there can cause a left atrial increased enlargement, a left axis deviation because of either fibrosis, LAHB, or because of the muscle mass itself can cause. So these are the basic criteria that you should understand, and because of these criteria you can actually give a lot of differentials, mainly that is because of ischemia. So if ischemia is present, the voltage criteria of LVH and LAE may be absent. It may happen with a patient who has already hypertension, but they may be absent, while LVH, if there are STT changes, are always present. J-point depression is generally present in LVH, may be absent in ischemia. There is an asymmetrical T wave as compared to a symmetrical in ischemia. The steep ascending limb of the T wave is there in LVH as compared to a ischemic patient. Overshoot is present in LVH, but in ischemia overshoot is absent. The inversion in V6 is generally more than 3 mm and generally less than 3 mm in ischemia. T wave inversion in V3 and V6, if you see, the V6 T wave inversions would be more in as compared to V3, while it is actually opposite in ischemia. STT changes are opposite to that of the QRS and can be both if the ischemia is causing an ST elevation. ST is convex upwards and especially in LVH, and it can vary in ischemia. So after that differential is reached, we need to find out if there is LVH or not by criteria. You can use single leads, you can use multiple leads, you can use a point scoring. There are multiple scoring systems which are available, but try to remember the most commonly used, and what I would describe would be a Sokolov-Loan voltage criteria, which is the easiest, which is based on the chest leads SV1 plus RV5 or RV6 more than 3.5 millivolt, that is 35 millimeter tall, or in the limb lead AVL is more than 11 millimeters, that is 1.1 millivolt. So if you have this, it suggests that the QRS voltage is more and it is an indirect indicator of LVH. However, many a times this may not be appropriate, and that is why a Romhild-Este score system is there, where voltage criteria is given 3 points, wherein if you see that R or S in any of the limb leads is more than 2 millivolts, or S in V1, V2 or R in V5, V6 is more than 3 millivolts, that is 30 millimeter, is given 3 points. A STT change opposite to that of the QRS complex is given 3 points, without digitalis, and with digitalis 1 point. A presence of left atrial enlargement is given 2 points. A QRS axis deviation is given 2 points. QRS duration, that is if your QRS becomes wide, is given 1 point, and intrinsic coil deflection of more than 0.5 seconds is given 1 point. So if the total points is more than equal to 5, then there is definite LVH. If it is more than equal to 4, that is 4 points, it is probable LVH. If it is 3 or less, it is not considered to be LVH by this criteria, and that is what we will see in the further. The others being Lewis index, the Sokolov and Lyon index, McPhail, Simpson's, Consul, Perugia, and others like Glasgow, as well as a criteria developed by Casal et al. Now these are being studied with various studies, and they have different sensitivity and specificity, but the most easy way to find out a LVH is a Sokolov-Lyon index, which can be seen by seeing only one lead or two leads, and the Romhild-Este scoring system. So these are the two general that you use, and if you have these criteria used, the sensitivity of a Sokolov is higher as compared to specificity, while of the Romhild scoring system, the sensitivity is lesser as compared to the specificity. So when you use both together, it gives you a better idea. So let us see the spectrum of LV pressure overload. Voltage criteria wise, in this patient, if you see, the S in V1 is 13, the R in V5, V6, if you see, is 32, total being more than 35 by Sokolov, but if you see Romhild, it's only the voltage criteria that is there. So Romhild says only 0.3, which does not satisfy the criteria as such. But by Sokolov, it suggests that there is LVH. So the basic difference between an athlete's heart ECG versus a pathological LVH would be that increased QRS voltage would be associated with upright T waves in an athlete's heart as compared to LVH, where it will be T wave inversions, and the Q wave will not be more than 4 millimeters or 25% of the R wave, and the width will not be more than 0.04 seconds, that is 1 small square. And athlete's hearts, it's a reversible, even LVH to a certain degree is reversible. As the LVH advances, what you get are these STT changes. So here the QRS voltages are higher, as well as there is a T wave inversion with ST segment going down, asymmetric in nature, which suggests a strain pattern, and this gives you a total scoring of 6, which satisfies both the Sokolov criteria as well as the Romhild criteria. Now differential of this would be a digitalis effect, and digitalis effect is characterized by this inverted moustache sign, that is a slurred, sagging, scooped reverse tick mark with a T wave which is upright thereafter, and it suggests digoxin. So in the presence of digoxin, the ST segment is considered to be only 1 point as compared to 3 points without digoxin. Going on further, what you can see is presence of left atrial enlargement, the QRS duration, the P wave duration increases in lead 2, as well as terminal negativity is more than 1, and you have gross QRS increased voltages as well as a strain pattern seen, which gives you a very high score of 9, which suggests that there is significant left ventricular enlargement. So here if you are seeing a wider QRS, so a QRS which is wide here as compared to a normal person also increases the sensitivity and specificity of a Rommelt scoring system. Further on, notched QRS, left axis deviation if you are seeing here would also cause and a delayed intrinsicoid deflection suggests presence of LVH, even though the R in V5, V6 is not very tall, but there is an increased S wave in V1, V2. So always see these two leads together. In pathological like HCM, there may be LVH and there is generally a presence of wider and notched QRS. So to differentiate plain LVH from a HCM, which is a pathological part of LVH, you may have more wider QRS and a notched QRS. Atrial enlargements may be present. There may be biventricular hypertrophy in occasional patients. So this patient had significant LVH by echo. Deep T wave inversions. If you see here in this patient, there are deep T wave inversions and increased voltages in V5, V6. So STT changes and increased voltage would suggest a hypertrophy, but in echo wise, if you see this basal septal and lateral wall is normal, it's only the apical hypertrophy. So if there are deep T wave inversions in V5, V6 specifically and which are there in other leads also may suggest an apical HCM. Characteristics of an restrictive cardiomyopathy, as you can see in this echo, there is a significant hypertrophy. However, if you see voltage in the chest leads, it is higher as compared to the limb leads. So normal voltages or low voltages in limb leads while preserved voltages in the chest leads is a significant indicator to restrictive cardiomyopathy, and it may suggest a amyloid type of cardiomyopathy also. So low voltage complexes, atrial enlargement, axis deviation towards the left and a late transition signify a possibility of a restrictive cardiomyopathy. Going on to left ventricular hypertrophy of the eccentric nature, which is due to volume overload, as we can see here, increase in the Q waves in nearly all the leads, inferior and even in the chest leads, as well as tall R waves if you see here with a normal upright T wave suggests an eccentric volume overload, and it actually would suggest that it is either cardiomyopathy or a volume overload due to a shunt lesion or a valvular heart disease. So if you have a LV volume overload due to PDA, fistula or others, only initially the voltage criteria are there and later on left atrial enlargement may come over a period of time and then left axis deviation would come. In an enlarged heart as compared to a volume overload heart, the left atrial enlargement comes earlier and left axis deviation would come earlier. There may or may not be increase in the PR intervals. There is a late transition mostly in such patients because the LV is rotated and a LBBB may come over later on. So presence of a late transition, left atrial enlargement and maybe a low voltage in the limb leads suggests a dilated cardiomyopathy. Differential diagnosis of LVH would be pre-excitation. You can see here the PR is normal, narrow as compared, so it is less than 120 millisecond, and you can have higher voltages in the lateral leads which may actually give you a false LVH. So if you have such patients with increased voltage, see the PR interval, and if it is actually less, then you should think of a WPW. Also MI initially, acute MI stage, there can be an increased voltage and the STT changes can be significant there, and that is one of the differential you should keep. Hyperkalemia can have an increased T wave, a peak T wave, which can be also as a differential. Going on to right ventricular hypertrophy, There are three major types of right ventricular hypertrophy. One is which is a typical right ventricular hypertrophy as characterized by a tall R in V1, prominent S in V5, V6. While type B, which is due to actually volume overload, which suggests incomplete RBBB pattern, which occurs with ASD or rheumatic heart disease, which suggests that R in V1 is more than 0.5 millivolt and R by S ratio is more than 1, and QRS in V5, V6 is normal. The third type is with chronic lung disease, wherein you have RS complexes in V1, V2 and R tall and S tall in V5, V6 with a right axis deviation or a right atrial enlargement in chronic lung disease. So basis again is the same. When you have RVH, the axis deviates to the right. You have increased voltage in the right sided leads. You may or may not have right atrial enlargement. You may have STT changes secondary to right ventricular hypertrophy and wider QRS or RBBB because of right ventricular hypertrophy, and this is actually included on all these criteria. So if you have an R more than 7 in V1 or the RS ratio is more than 1 in V1, S of more than 7 in V5, V6 or RS is less than 1 in V5, V6, of the Sokolov-Lyon criteria, R in V1 plus S in V5, V6 is more than 11, right axis deviation of more than 110 degrees, QRS duration of more than 120 milliseconds, right atrial enlargement with a strain pattern in V1 or the inferior leads, or S1, S2, S3 in the ECG if it is there, suggests right ventricular hypertrophy. So seeing this patient, the R in V1 is more than 7 and R by S ratio is more than 1, and you have STT changes in the anterior leads with a little bit of right axis deviation, suggests right ventricular pressure overload. As the R wave, as the pressure increases, and you can see that there can be a QR pattern which may suggest a right atrial enlargement also to a certain extent, but you gradually have more right axis deviation and the QRS becomes more wider. So it is very important to understand that as the degree increases, the voltage would increase, and more the RVH increases, there may be secondary tricuspid regurgitation causing right atrial enlargement, which may be reflected on the ECG. So increased voltage in the V1 and increased S wave in V5, V6 along with right axis deviation and right atrial enlargement with a wider QRS suggests RVH. Now certain congenital heart diseases have right ventricular hypertrophy like TOF. However, they have a specific pattern wherein the transition is immediate in V1, V2, and it should be remembered in such patients that if you have a congenital heart disease, then with a specific pattern TOF should be considered. Here you can see right atrial enlargement along also. Also in a patient who has pulmonary embolism, acute strain pattern can be there. Sinus tachycardia, however, is the most common feature. You may have RBBB and you may have an S1 Q3 T3 syndrome. So pulmonary embolism acutely can cause RV strain pattern along with RBBB and a specific sign as S1 Q3 T3. However, sinus tachycardia is the most common. Going on to the second type, that RVH, that is volume overload pattern. Here you have more of an RBBB, broader QRS. However, the STT changes are not prominent. So the ST segment and the T wave go along with the QRS, and you may have something called as a notching in V2, lead 2 and 3, which is more specific of a ASD. It's called a Crottiet sign. After the ASD causes volume overload, pressure overload sets in, and then gradually the changes may occur, and wherein the R wave height becomes monophasic. So T wave becomes upright in V2 and S wave comes in V5, V6 thereafter, and there are then chance seeing right atrial enlargement. And finally, when PH sets in, then pure RVH sets in rather than the RBBB nature of volume overload. Coming on to the last third variety of RVH, COPD. Here you can see that there is a transition which is late. So transition late, inferior axis and a presence of right atrial enlargement suggests that this is likely a COPD patient with a right atrial enlargement and RVH. So criteria wise for RVH, again, the sensitivity and specificity. So sensitivity is less, specificity of most of the criteria is very high. You have to differentiate it from WPW pre-excitation, especially left-sided pathway where you can have an RBBB pattern which may give a pseudo chance that you have a RVH or a MI pattern, especially posterior wall MI. Biventricular enlargement as seen in shunt lesions or hypertrophic cardiomyopathy or valvular heart disease. Here you can have a combination of voltage LVH criteria with right axis deviation or patients having RVH with left axis deviation or biatrial enlargement. So it's very important to understand that diphasic RS complexes in mid precordial leads, if it is more than 50 millimeters, it's called a Katz-Watzel seen classical with VSD. Biventricular hypertrophy here in this ECG is characterized by RVH and V1 being monophasic and also V5, V6 being tall R waves with lesser S waves in V5, V6. The axis is towards a right side in this patient or an indeterminate. Global T wave inversions along with some voltage criteria in V5, V6 can also, along with right axis deviation, is also considered to be association of biventricular hypertrophy. In Eisenmenger's, especially with the VSD, you have tall R waves, very tall R waves in V1. Along with that, it consists of V1 to V6 all remain tall with severe STT changes, especially in the anterior leads, that is chest leads, and the inferior leads. Lastly, to the low voltage criteria, if the QRS peak to peak is less than 5 millimeters in limb leads or it is less than 10 millimeters in precordial leads, they are considered to be low voltage, and the causes of which can be because of voltage dampening, that is external factors other than the cardiac, that is obesity, COPD, pericardial effusion, thickening, left-sided pleural effusion, subcutaneous emphysema. It can also be because of loss of viable myocardium, wherein there is a large MI or a dilated cardiomyopathy with significant fibrosis. Lastly, because of infiltration like amyloidosis or hypothyroidism can cause low voltage. So if you see this ECG, the less than 5 millimeters in peak to peak in the limb leads and less than 10 millimeters voltage in all of the chest leads suggests a low voltage ECG. Now here the P wave voltage has not decreased and there is presence of a left axis deviation and left atrial enlargement, which suggests that this is likely to be a LV cardiomyopathy. Here biatrial enlargement is present. The peak P wave is present in lead 2 as well as left atrial enlargement with low voltage in left axis, and sinus bradycardia suggests again to be cardiomyopathy rather than a low voltage because of dampening. So if it is dampened, the P wave and the QRS as well as the T wave nearly remains normal. So no other P wave or QRS abnormality if it is seen, the heart rates are normal, no axis change is seen, then it is more likely to be dampening related. This is a classical QRS alternance seen in pericardial large effusions where the P wave and the QRS are seen to be low voltage. However, if you see that the P wave morphology doesn't suggest any atrial enlargement. So what are the limitations of diagnosis overall? There can be masking of hypertrophy because of obesity, pericardial effusion, pleural effusion, pneumothorax and subcutaneous emphysema, COPD, post-operative patients, and many a times half standardization ECG can actually cause a false ECG of normal voltages. Higher voltages is generally seen only in increased standardization or thin lean with flat chest. Difficulty in diagnosing LVH or atrial enlargement is because of bundle branch blocks if it is there, or the heart has shifted, or sometimes the ECG electrodes are placed wrongfully. Sometimes artifacts and electrolyte imbalances also can mask the diagnosis. So summarizing, ECG is a very good screening test for diagnosing chamber enlargement. It has to be confirmed by a echo. However, apply the criteria and context of the patient's clinical scenario, whether the patient is on medications, whether the patient has chest pain, or what is the baseline underlying condition. ECG criteria should be objective. It cannot be subjective that you see it. So you use criteria which are there. Keep in mind the limitations in presence of bundle branch blocks, or the patient has a chest abnormality, and often a presumptive diagnosis can be reached by using the ECG, using these criteria properly. Thank you.